Hello, everyone. I'd like to welcome you all to Pediatric Grand Rounds. And I'm going to turn it over to Dr. Meredith Russell to introduce our speaker for today.
Hi, welcome everyone. It is my pleasure to introduce Dr. Benjamin Chaffee. Dr. Chaffee is Associate Professor of Oral Epidemiology and Dental Public Health and Director of the UCSF School of Dentistry program in Global Oral Health. His NIH-funded research includes studies of new and emerging tobacco products, dental professional engagement in tobacco cessation, early life influences of children's oral health, and dental caries management. Dr. Chaffee has authored more than 100 academic publications and has been nationally recognized for excellence in teaching. Dr. Chaffee is motivated to understand how better policies and practices can enhance health behaviors in childhood and adolescence to advance health and happiness into old age, which is, I think, a passion that many of us share here at UCSF. It is my pleasure to introduce Dr. Chaffee to discuss kids and cannabis in California. Thank you.
Well, thank you so much. Thanks for that introduction, and thank you for the chance to present today, and to everyone for taking a little bit of time out of your day to join this session. So my name is Ben Chaffee, and as you heard, I'm coming from the School of Dentistry. A great opportunity to speak to colleagues from across the campus. And the topic today is on mostly adolescents and on use of cannabis and what our research team has learned from some of our work here in California. Quickly, I'll point out that I have no affiliations with any tobacco, e-cigarette, cannabis, or pharmaceutical company. I do some consulting that's related to the population assessment of tobacco and health, an FDA and NIH-funded study. And my team and I have been supported by a number of different grants and contracts from the California Department of Public Health and the NIH. And while the topic I plan to discuss today is about cannabis and implications for health for adolescents and their families, visiting from the School of Dentistry, I really want to take the opportunity just to highlight the opportunities for synergy between the different professions and to really be complementary of all the efforts that pediatricians have made to advance the oral health of their young patients. As you know, one of the most important things you can do for a young child is to connect that child and their family with a dental home, a place where that child can go for care, for routine care, or for emergency care when a need arises. And particularly for very young children, or for children who are at high risk of tooth decay or who have other special needs, working with a pediatric dentistry specialist is very important. Certainly, promoting a healthy diet, and number one, that means reducing the intake of sugar from drinks and from foods is going to promote a healthy mouth that's free of tooth decay. And remember to encourage those kids and those families to brush teeth. A parent or guardian really needs to be there to help a child and assist them with toothbrushing until they gain the necessary dexterity to do it themselves. And that probably is happening around age 7 or 8. Toothpaste appropriate for any child, including with fluoride as soon as that first tooth emerges. But the amount of toothpaste you want to use is very, very small. Those 1-year-olds, those 2-year-olds, you're using just a smear, the smallest amount you can see on the bristles. And then when your children are about 3, 4, 5 years old, you can start putting on a toothpaste dollop the size of a pea. Very important, managing dental injuries, preventing them, encouraging the use of a mouth guard for your older child patients who are playing sports, but also knowing what to do when a child shows up in an emergency department or in your practice with an injury to the teeth or jaws. And I love it when I go in and take my young children to see their pediatrician and they're offered fluoride varnish applications. That's one of the great things that you can do to prevent tooth decay in kids. And it is a payable service for physicians that's related to oral health. So happy to be here. Couldn't get through without saying a few words about oral health. But today I want to talk about one current area of my research interest, and that has to do with use of cannabis among adolescents. And again, as a dentist, my journey as a researcher and epidemiologist began very focused on young children, preventing tooth decay, and how factors in early life, nutritional factors, breastfeeding and transition to complementary feeding, and then eventually to full table food adult diet, or adult resembling diet, how that can be used and harnessed to prevent tooth decay in kids. But I had the opportunity some, say 9 or 10 years ago, to become invested in tobacco research and tobacco control. And my first reaction to this was, well, what is there left to know? We know that smoking is terrible for you in every possible way. But around the same time, the landscape around tobacco was changing rapidly. This was about the period in which electronic cigarettes, or vaping, began to really gain prominence and popularity. And the FDA, that also gained regulatory authority over tobacco products around this time, wisely funded a research program, what they called tobacco regulatory science, to develop the evidence base to inform their regulation of these new and existing products. And so that's the work that I've been doing with a very talented and larger team. And you can't study tobacco use among adolescents if you're not paying attention to vaping. And you can't look at vaping and tobacco if you're not paying attention to cannabis use. And researchers have termed these three products together the triangulum, because they share a lot of similarities, they share a lot of the same risk factors, and many individuals who engage in one of these products is also engaging in the other two. So they're all, there's a lot of interplay between them that we'll get into in this talk today. And I want to clarify, I've been using the word cannabis quite a bit, and I will be using cannabis and marijuana as umbrella terminology in a more informal and interchangeable way. But certainly within cannabis, there are a lot of different products that do have some differences in terms of their chemical composition and how they're regulated and how they're used socially. So hemp is different than marijuana, is different than, say, a cannabinoid-based product like CBD, and whether somebody's using that to get high or with another medical purpose in mind. Those subtleties are important, but for most of our purposes, we can have a conversation just using cannabis or marijuana in a general sense. A lot of complexity there. When we talk social politically, one of the most striking contradictions is that, as you know, marijuana is a Schedule I drug at the federal level with therefore no accepted medical use under that designation. But in more than 30 states, and about 11 of which allow recreational legalized use, this is a product that people can purchase and use legally. And those 33 states cover something like more than 70 to 75% of the US population. So when people think about marijuana, there are so many cultural touchstones that bring a lot of different, perhaps conflicting ideas to mind. Reefer Madness, a terrible movie from the 1930s that gained notoriety not for just its terrible acting, but for the basic thesis that a couple of puffs of a marijuana cigarette will be enough to ruin your entire life and send you into madness and off on a murderous rampage. But also, we can lean on cultural references where marijuana use and promotion is a way to rebel against the social structures, against the more powerful and oppressive governments or other forces. Whether you're a hippie or a hip hop artist, this is a way to be anti-establishment. Marijuana use is portrayed as something funny. The idea of the slacker or the stoner, this is something laughable, is prominent and prevalent across the cultural landscape. And here in California was the starting point of marijuana as medicine. With the passage of Proposition 215 back in 1996, there was a lot of advocacy from patients to say, we want access to marijuana as a way to control pain. And this set off a wave over subsequent decades, that, as we saw, now up to 30 plus states allowing at least some form of medical marijuana access. And more recently, we've seen this evolve from a limited scope of medical uses in certain situations to now a widespread health and wellness product of different products, not necessarily used to get a high, but derived from a marijuana plant for all sorts of medical purposes, with the efficacy and research behind those purported claims, in many cases, substantially lacking. So I give that lengthy background just to say that it is no surprise whatsoever when young people and their parents, patients in your practice, are uncertain or confused about what to think about marijuana. It is all these things at the same time, and in many cases, conflicting with each other. I get confused enough trying to hold all these ideas together in my head. I can just imagine for a 14 or 15-year-old trying to piece this together. So speaking of those teenagers and their peers, sharing a little bit of information in terms of recent trends on the use of marijuana in the United States. So the data on this graph come from the Youth Risk Behavioral Surveys. This has been a longstanding, every other year surveillance survey conducted by the CDC in the United States. And what's striking about this is that current marijuana use, if you just squint and look at this graph quickly, is basically flat over this nearly 3-decade period. So in this context, current use of marijuana is defined as using marijuana or pot, weed, or cannabis at least one time in the past 30 days. And this past 30-day use reference point is important for cigarette smoking, e-cigarette use. It's very commonly used to measure substance use among adolescents and has pretty strong predictive power for future use, say 1 year or even into adulthood. And yeah, there is some modulation here. Use was highest in the mid to late 90s. This is also around the same time that youth cigarette smoking peaked. But really, going back to the 2010 or even earlier, we haven't really moved too much from that about 1 out of 5 high school students reporting past 30-day use of marijuana. There are, of course, some differences. Certainly by age, you'll see more use among older kids than younger kids. By gender, not a meaningful difference. This particular reference point from 2019, slightly higher use among boys than girls. There are some much more substantial differences by race, ethnicity, use being the highest among youth identifying as American Indian or Alaska Native, and lowest among those identifying as Asian, and also high among those identifying as one or more races. And this stands up in a number of different national surveillance studies. It's not unique to the YRBS. Notably, though, among Black, African American, Hispanic, Latino, or white, use prevalence relatively comparable, about the same level. There are some strong differences among LGBT identifying youth, defined in this survey as gay or lesbian, bisexual, or both, being higher than among those youth who identify as heterosexual. And use higher among youth who have some form of sexual contact than among those who don't. But that's probably strongly related to age, of course, where the youngest kids are less likely to be having sex and also less likely to be engaging in substance use. But going back to that same idea of marijuana use being essentially flat across the population in the last couple of decades, that is against a backdrop of very severely declining or very steeply declining cigarette smoking. So cigarette smoking, like I said, peaked in about the late 1990s and has been just dropping like a stone, fantastically, ever since then. But yet marijuana has persistently remained about the same. These percentages are a little bit lower than on the previous slide because the kids in this study are a little bit younger. And at the same time, use is staying flat. Attitudes around marijuana are also changing, both among adults, but here particularly among kids. Rising prevalence of the percentage of kids who say that using marijuana just once or twice a week has no health harms whatsoever. So that same idea of declining cigarette smoking, but flat or even increasing marijuana use was highlighted in this paper that came out in the American Journal of Public Health a couple of years back. We're just looking at the two ends of that youth risk behavioral survey. In 1991, comparing to 2017, cigarette smoking dropped, marijuana use went up, but remember most of that increase happened in the 90s, about flat since then, and alcohol use also coming down quite a bit. And so what you're seeing is that very, very rarely are kids only smoking cigarettes without marijuana or alcohol. And again, alcohol use alone without these other substances dropped about in half, but use of only marijuana without cigarettes or alcohol, that went up tenfold. It's still a small overall percentage of the population, but what you're seeing today compared to 3 decades ago, much more likely to have, whereas 3 decades ago, any kid who was smoking marijuana was very likely to also be smoking cigarettes and using alcohol, whereas today, a substantial portion of kids who are using marijuana are using it exclusively without any other tobacco or alcohol product. And so one thing that some of these studies I showed you that weren't up to the minute to the 2020s, tobacco use now is almost all e-cigarettes or vapes. This 15 to 16% prevalence of past 30-day tobacco use among high school students in 2021 is almost all comprised of vaping. And alcohol and nicotine vaping are still a little bit higher than marijuana use, although marijuana and vaping are almost, in almost every survey, are about the same in this age group in terms of prevalence. And in many cases, that's overlapping about the same kids. There will be vaping nicotine will also be using marijuana in one or another form, whereas use of cigarettes, cigars, and more conventional chewing tobacco are much, much less common. And so, yeah, vaping. People are consuming marijuana in a variety of different ways. It's not just smoking it, it's certainly vaping it as well. And the devices that are used to aerosolize a liquid containing THC or other cannabinoids so they can be inhaled, this technology and the devices look very much the same, resemble devices for vaping nicotine. In fact, in many cases, go on YouTube and do a little investigation, as you know, our adolescents do. You can find all sorts of ways to tamper with or change your nicotine delivering Juul or other devices in order to use it to vape a cannabis product. Vape cannabis, not the only way that individuals are finding more and more variety of ways to consume cannabis. This is not just adolescents. This survey here is from a large panel including adults, so age 16 to 65 in both the United States and Canada. And so in this age group, among past year cannabis users, the vast majority used the dried herb, whether it was in a joint, a blunt, smoke from a bong or a pipe. That's still the most common way to deliver a cannabis product, particularly among adults. But look at this use of edibles becoming very common, vaped increasingly so, and all these other formulations in which these products can be delivered. One of the points made in this research study was that in US states that had some form of a legal marketplace, these other alternative edible or vape modalities for delivering cannabis were in general a bit more common. You'll also notice if you look at these percentages is that they very easily add up to more than 100%. That tells you that among these cannabis users, they're consuming the product in a variety of different ways. And that has a lot of implications for health. The health effects of consuming cannabis may be different depending on how it's delivered. And we have a lot less research behind any other form other than smoking it. That last slide mostly included adults, but the same kind of trends are present among adolescents. In this analysis, looking at the Monitoring the Future study, it's a study that's been going on since the 1970s that serially surveys 8th, 10th, and 12th graders in the United States. And the graph's a little bit funny, but what they're looking at are individuals who said that they used cannabis in the past 30 days and also vaped cannabis in the past 30 days, at least among the different ways they consumed it. And so the solid lines show the prevalence of consuming cannabis, including with vaping it, the blue lines being frequently, at least 6 times in the past 30 days, and infrequently in the orange, 1 to 5 times. Both those behaviors are going up just in recent years, 2017, 2019, and using cannabis in other forms exclusive of vaping, those behaviors are going down. And so this is a quite rapid and recent change in the way kids are consuming cannabis. So we looked at some changes in potentially how much these products are being used and who's using them, also the products and how they're using them. what they're actually consuming is also changing. This is a look at cannabis products that had been seized by the Drug Enforcement Agency from 1995 to 2014. And the products are becoming more potent on average. The products that they tested, the concentration of THC, the chemical found in cannabis products that's intoxicating, gives you a high, has tripled in its concentration in just 2 decades. And CBD, another cannabinoid found inside cannabis that is not intoxicating, that concentration on average across these products is declining. So we now have at least in 2014, an 80-to-1 ratio of THC to CBD in these illicit products seized by the DEA. And my hypothesis would be, in more recent data, that these trends would have continued. And that we would also see a similar increase in potency in products that can be purchased on a legal marketplace in dispensaries. Just briefly, because I've started talking about THC and CBD, a couple of slides on the pharmacology is that the cannabis plant is, of course, very complicated, containing many different compounds, including the terpenes that give cannabis consumer products different odors and flavors, and dozens, 100 or more different cannabinoids, the most well-known of which, delta-9 THC, that's the one that's psychoactive, or most well-known as being strongly psychoactive. And it interacts with the body's own endogenous endocannabinoid system by binding to CB1 and CB2 receptors. So the endocannabinoid system has regulatory control over a number of different processes across the body, including inflammation, appetite, immune function, cardiovascular function, pain, and sleep-wake cycles. And so when THC binds to these receptors, it's a strong agonist. It decreases neurotransmitter release. And so the effects of this product are related to the systems that, under its control. So you'll see issues with learning and memory and spatial orientation, elevated heart rate, possibly reduced pain sensation, and also some anti-inflammatory effects. So some of these effects have been harnessed in FDA approved as safe and effective prescription medications. So a couple of cannabinoid-based drugs that are synthetically made, dronabinol and nabilone, these are used to treat nausea in patients undergoing chemotherapy. And Epidiolex, which has been approved, I believe, just 4 years ago, this is a plant-based CBD. It's essentially 90+% CBD and can be used to treat epilepsy in children with certain syndromes. But the main thrust of this talk is why cannabis use or rising acceptance and normalization of cannabis use among teenagers is tied to some important health concerns. Now, what I'm not going to talk about are more chronic disease outcomes. So cannabis smoke shares many of the same chemicals as tobacco smoke. And you'll see that long-term use will be associated with many of the same chronic disease endpoints as cigarette smoking. So heavy cannabis smokers over time will be at higher risk of respiratory and cardiovascular diseases. Coming from an oral health perspective, higher risk of periodontal disease, gum disease, and tooth loss. But those are conditions that tend to affect individuals later in life. And I want to focus on some of the more immediate implications for our adolescent patients. And to start with, adolescents in general, compared to adults, are more sensitive to THC. In this study, a very interesting design, relatively small samples of adults and adolescents, I think ages maybe 18 to 20 versus adults in their later 20s and 30s, were given THC under controlled conditions and asked to report their level of intoxication. And at the same level of feeling high, the adolescents had more impairments, whether it's their different tests of cognitive functioning or actual brain scans. There were more functional changes in the kids at the same level of high as in adults. And so these effects acutely are problems with perception, with concentration, in some cases, more severely, psychosis, even suicidal ideations. And at very high concentrations, there can be toxicity. sedation and depression of breathing, vomiting, and I talked about tachycardia, and it could be an expression of cardiotoxicity. And so somebody impaired, using a THC-containing cannabis product is going to have trouble driving a car. Research on this suggests that it's about double the risk of being involved in a motor vehicle accident. Seems to be more risk in occasional users of cannabis than in chronic heavy users, and of course more risk when combined with alcohol consumption. Now, there is some controversy around these studies of driving impairment, because it has also been shown that individuals intoxicated with THC tend to drive slower. And that is true, but you may still be at more risk of motor vehicle accidents because it's difficult to complete these complex tasks. So if you have lots of traffic around you, pedestrians, multiple lanes, bad weather, and you really need to focus and concentrate, you are not as safe a driver than when you are not under the influence. And really important for our adolescents, this is a critical period of brain development. And cannabis appears to have some interference and cause some impairments in that developmental period. These data come from the Dunedin birth cohort study in New Zealand. So this is a fantastic study where essentially in Dunedin, this city, all babies born from 1972 to 1 year later were invited to enroll in this study and have now been followed for 50 years. And as part of this birth cohort study, children underwent neurological testing at age 13 before any of them had begun using cannabis. And again, that testing was repeated at a follow-up visit in adulthood at age 38. And so those individuals who were categorized as persistent cannabis users, that means that at multiple waves of follow-up between age 13 and 38, they reported that they were using cannabis, they saw greater declines in their IQ compared to individuals who were not using cannabis. And it wasn't just IQ, it was actually across the board impairments on all these different neuropsychological testing metrics. And the declines were most pronounced in the individuals who began using cannabis earlier, in adolescence, prior to age 17. And so in addition to these cognitive impacts, there's also a number of social outcomes that appear to be worse in adolescents who use cannabis. So this is another longitudinal study, also from the same part of the world, from Australia and New Zealand, a larger study that, depending on the outcome being measured, had anywhere from 2,500 to 3,700 observations available. And they're looking at outcomes in adulthood at age 30 as predicted by cannabis use at age 17. And those who were using cannabis as teenagers were less likely to have finished high school, were more likely to be users of other illicit drugs, so heroin, cocaine, misuse of prescription opioids, and had greater odds of having attempted suicide at some point. And you can say, well, those outcomes in cannabis use potentially share a lot of the same risk factors. Well, there's a lot of statistical modeling in this paper to try to account for that confounding, and done in a number of different ways. I think they had somewhere in the neighborhood of 50 different factors considered in their statistical analysis, and about half a dozen or more different sensitivity approaches. And these results, these associations remain robust no matter what they threw at the numbers. And while most people who use cannabis will not become addicted to it, or at least not dependency in the same way you'll see for, say, a nicotine-containing tobacco product, still somewhere in the neighborhood of 1 out of 10 will develop a cannabis use disorder. And so defined broadly as using cannabis for more than a year with at least one finding of either addiction, an important social or physical impairment or distress. And those people who become dependent on cannabis, who then try to stop, will go through a period of withdrawal. And those withdrawal symptoms can be quite uncomfortable and quite difficult to manage in terms of anger, anxiety, problems with sleep, pain, sweating, fever, and so forth. And there do seem to be some groups of individuals who are at more risk of cannabis use disorder than others, tend to be male, lower socioeconomic position, greater risk of cannabis use disorder in people identifying as Native American, American Indian, and in younger individuals, much more commonly than in older adults. Or adolescents and young adults are greater risk for disorder than their elders. And also just an important note for thinking about kids, even younger kids, with increasing use of edible products, with the cookies, the candies, the drinks that look like food and treats, we're seeing a rising prevalence of unintentional ingestion of cannabis products by kids. This was studied particularly in Colorado, which was one of the very first states in the United States to legalize recreational use of cannabis, and it was followed by increases to poison control centers and emergency departments. And of course, this is serious. You don't want toddlers and young kids eating marijuana, although fatalities extremely, extremely uncommon. But you will see some serious events in some cases requiring hospital admission to deal with these kids. And I'll say too that you've probably seen, if you look around in your gas station or convenience store, that there are a lot more CBD products out there. And there are some parents deciding to use these products for themselves, for their children in some cases, and look on the internet, sure enough, for their pets. And one reason why these are out there is that in a recent farm bill, hemp products became legal at a federal level that contained lower than a very low threshold of THC, and that opened the doorway for a lot of these now lightly regulated CBD products to start showing up on store shelves. And this is just a reminder that the safety and efficacy of these products is just, in many cases, not well known. Are there benefits? Maybe. Are there serious risks? Plausibly. But it is something that is recent and seems becoming much more commonplace. Something that may be motivating for patients in your practice or their parents is that just because you're using a CBD product doesn't necessarily mean you will not test positive for THC if that's something that is important for, say, employment or participation in sports, which is important for many of our adolescent and young adult out there. So be careful about what you're putting in your bodies. And I want to say a few words about a condition that came to be known as e-cigarette or vaping-associated lung injury, or EVALI. This caught a lot of headlines in the summer of 2019 when, mysteriously at first, a number of young people were admitted to hospitals, beginning in the Midwest, with really severe cases of lung injury. And what was notable about these cases is that the patients tended to be younger, teenagers, young adults that didn't have any history of any other health ailment. But what they did seem to have in common in interviewing these patients was that they were current or recent vapors. And most of those who reported vaping also reported using a THC-containing product. Not everybody, although you can understand why people might be hesitant to report use of illicit substances on an interview. And I'm not a physician, so those in the audience can read these images much better than I, but when I look at these CT scans, my first take is that's not good. You see this ground glass appearance throughout the airways, where you really want to see that dark, clear spaces with lots of room for gas exchange. And this outbreak peaked in the late summer, early fall, and continued through the winter. And all told, there are almost 3,000 hospitalizations and unfortunately 68 deaths. Now, right around that time, February 2020, the CDC stopped tracking this outbreak. You could argue justifiably so. There was a much more serious outbreak, of course, COVID-19, that was starting to take hold in this country right around that time. But generally, these patients were coming in with pretty serious disease, trouble breathing that was not caused by infection. And in many cases did resolve in about a week with corticosteroids and stopping vaping. And so with a lot of detective work from different public health agencies around the country, led by the CDC, eventually what this was linked to was vaping of illicit cannabis products that contained vitamin E acetate, also known as vitamin E oil. And this is a product that's been around for a while. It can be used topically in hand lotions. It's actually added to some vitamin gummies that people will eat. But it's been known that this product is not something that should be inhaled. Nonetheless, it had some interesting properties that were advantageous if you were selling illicit cannabis products. So if you're trying to extract THC from a cannabis plant, it's very viscous and oily. I mean, it's called wax or butter, or even more brittle form of shatter. And so in order to get this into a liquid form that can be heated up and aerosolized in order to vape the product, you need a diluting agent. And there's a number of different diluting agents out there, but why vitamin E oil became popular for a time was that it was effective at diluting THC wax, but it also maintained this thick yellowish appearance after dilution. So for buyers who were looking for a product that had a lot of THC to get them high, they didn't want to see something that's been heavily diluted. They wanted to see a nice thick liquid in their wax pen to use to vape it. And so this was very popular in people who wanted to dilute their product to enhance their profits and still make it sellable and presentable to their customer base. And unfortunately, it put a lot of people in the hospital and killed some of them. And I think there's a couple of important take-homes about this lesson. So for one, this EVALI outbreak did seem to die down rapidly after word got out of what the causal agent was, or the most probable causal agent was. And that this is a product that was shown up in the illicit marketplace, that people were selling cannabis products out of the back of their car in a back alley, and we're placing this cutting agent. It's something you would not find. It's not allowed to be used in a regulated dispensary. And that is at least one argument to support a regulated legal marketplace for safety reasons around these products. But I'll also say too, while yes, we're probably not going to see more EVALI from vitamin E acetate now that we have an understanding of what was causing it, it's a notable example that there's a lot of things we don't know about taking stuff, aerosolizing it, and breathing it into your lungs, whether you're breathing in nicotine, THC, or something else. If I had to predict, unfortunately, I would imagine that we're going to learn the hard way about more of the unknown consequences of vaping various products. So that was a long introduction, but I do also, before we adjourn today, want to share some work from our team done here in California. I want to highlight two different studies that we've worked on. One that we call uncreatively the California Adolescent Health Study is part of the UCSF Tobacco Center of Regulatory Science. I talked about how the FDA has funded different centers around the country to develop evidence, in our case, looking at perceptions and behaviors of adolescents related to tobacco, that evidence that could then inform decisions that the FDA makes about tobacco products. So in this study, we followed a cohort of more than 1,400 teenagers that were recruited from 8 different high schools in rural parts of Central and Northern California. It was really important for us to go out to rural communities, one, where use of tobacco products has historically been higher, and where participation research has been less. Other study I'll highlight from our team is the Teens Nicotine and Tobacco Project. This is a collaboration through contract with the California Tobacco Control Program. And we do online surveys. We actually do 2 surveys per year of 2,500 each of 12 to 17-year-olds in California, with a goal to understand their perceptions, their vocabulary, their attitudes, their behaviors around tobacco products and cannabis to better inform surveillance and policy efforts across the state. And I want to acknowledge before I miss the opportunity, the fantastic team with which I get to work with these on every day. And you'll see some overlap here too. We've got some great synergy across the 2 projects. And California is an interesting place to work in this space. Well, California is an interesting place to work, period, for any number of reasons. But when it comes to tobacco and cannabis, the irony here is that you have a state that has this long history of being a leader at the forefront of tobacco control. One of the first states to have smoke-free bars and restaurants. and yet at the same time is very staunchly supportive of liberalizing policies around cannabis. And it's just easy to pull from the headlines, San Francisco being one of the first cities to pass a comprehensive ban on all flavors of tobacco products. And just a couple of months ago, also saying, hey, fair game to sell cannabis legally at the 420 celebration in Golden Gate Park. And so again, contradictions that we hold in our minds at the same time. And I'll put this in here. It's a bit more of my own thoughts on legalization. I spoke to this a little bit earlier, is that there are some benefits of having a legal regulated marketplace, that decriminalizing possession and sales of a small amount of cannabis and keeping people out of the criminal justice system is, of course, a good thing. Being able to tax this marketplace and then apply those tax dollars towards public health promoting programs is a benefit. And by regulating this marketplace, you can watch out for safety considerations, such as additives like vitamin E acetate. But there are clear drawbacks here of over-commercialization. One, that as this really becomes big business, it's very easy for business interests to elbow their way at the table and push public health concerns further down the agenda. And from my perspective as a researcher who works with adolescents, I'm always worried about increased normalization, increased access, leading to increased use of these products and then subsequent health effects among young people. And one of the things we've learned, and I talked about the contradictions of San Francisco policies around tobacco and cannabis, and maybe that comes from the standpoint of thinking about these products as something you breathe into your lungs to get a high that are possibly bad for you. Young people in the state don't necessarily pack these things together in the same bin. That cannabis, tobacco with nicotine, and vaping are very different things. And one way that we teased out that in a little bit more detail are using these conditional risk perception assessments in some of our surveys. So our colleague Bonnie Halpern-Felscher did some really important work developing these measures for tobacco use, where we essentially asked teens to say, hey, even if you don't use these products, imagine that you do. And we do this separately for cigarettes, for vapes, and for marijuana. And we say, okay, imagine that you use them. What are the chances from 0 to 100 that various things would happen to you? And they could be bad things like getting into trouble or getting sick, or they could be even good things like getting along better with your friends. And these perceptions of harm and benefit have been shown to predict future behaviors. And more of that work on tobacco products, but increasingly it's become important to look at cannabis too. And so really quickly looking at this figure, here are perceptions as they relate to cigarettes. And these are the average reported probabilities in our sample of these things happening to you. And again, it's not important to us that their perceptions of probabilities are correct. People are bad at predicting the probabilities of outcomes. It's how do their perceptions differ relative across the products and across the different outcomes. And so for cigarettes, the chances of bad things happening, getting in trouble, getting lung cancer, having worse health in general, were perceived as being fairly probable. And the possibility of benefits of having fun while you're using them or getting along better with your friends is somewhat improbable. And that general pattern was also true for vapes and marijuana, but you can see the risks coming down and the probability of benefits coming up. And even more pronounced, you go from vapes over to marijuana, that fewer risks or fewer chances of risks and greater chances of benefit. To the point where overall our youth are saying, yeah, there's almost close to a 50-50 chance that if I use marijuana, I'm going to have fun when I use this, and I'm going to get along better with my friends. Differences, of course, are very starkly different between users and non-users. In the gray bars or the lighter colored bars for each of these products are non-users' opinions. So they see greater chances of risk and lower chances of benefits. And the users, of course, they see lower chances of risks and greater chances of benefits. But if you go all the way over here for marijuana, one, even the non-users see it as quite plausible that they'll have fun and they'll get along with their friends if they use it. And among those users, those dark green circles, they see the probability of a benefit of using marijuana as very, very probable. And the probability of a harm or a risk, well, yeah, sure, I could get into trouble, but my health as being quite improbable compared to the chances of those benefits. So it's not surprising that many youth are drawn to trying these products. One of the other things we asked about is not just your current perceptions of what might happen, but what do you yourself envision when you're an adult? And we have to define that. We say when you are age 25, which is a distant future for these adolescents in their minds. When they say, well, what are the chances you will use this product? It could be definitely yes, probably no, or definitely no. And what's been shown in this kind of question setting is saying anything other than a staunch definitely not is predictive of being susceptible to future use. That you waver in that definitely not, there's a decent chance you'll be experimenting with these products in the future. And again, most of our sample doesn't see themselves as using these products as later as young adults. Product users, though, only 6% of current cannabis users say there's no way I'm going to be using this when I'm an adult. But for cigarettes, 1 out of 5 say, yeah, I'm probably going to quit this. And even non-users, there's some wavering here. There's still 1 out of 4 non-users of marijuana who are open to the idea that, yeah, this is probably something I'll start using when I'm older. Just switching gears to show a little bit more data before we break for questions. One thing we asked in our Northern California cohort was, are you using cannabis with flavors? There's been a lot of focus on flavored tobacco and tobacco control space, and less so on unflavored cannabis. And so while cigarettes, about 44% of cigarette smokers said they were using menthol cigarettes. And it was quite common to be using chewing tobacco, cigars, or vapes with flavors in them, using either smoked or vaped cannabis. It was a comparable percentage of these past 30-day users who said they use some flavored variety, whether it was in the wrapping paper, the rolling paper, a flavored blunt cigar, or a flavored cannabis itself. That was substantial. And in fact, so that was work by Miranda Wirtz, a research associate on our team who led this effort. A postdoctoral researcher, Alton Croker, then looked at these same questions in a larger survey done by our team. This is actually a national survey of adolescents and young adults up to age 20, and broke it down even further. That people who were using dry leaf cannabis, about 1 out of 4 said, yeah, they were using a flavored dry leaf product. 1 out of 4 smoking joints in flavored rolling paper. Blunts, the majority using a flavored cigar. And so that users of any form of cannabis, about 2/3 of them were using at least one flavored product in the past month. And if you count edibles as a flavor, it's the vast majority. It's 80% of cannabis users are using something with a flavor in it in the past 30 days. So one of the points Miranda made in her paper is that there's a lot of overlap here in availability of flavored e-cigs that can be adapted for vaping cannabis, or these cheap flavored cigars that can be used for smoking a blunt, that restrictions on flavors in those products may have a benefit on also making cannabis use less appealing for adolescents. And there's a lot of synergy potentially between tobacco and cannabis control. And one more thing I want to share. Our cohort of adolescents in California began before the pandemic. And in fact, we had staggered our enrollment, so some of it began a year before the pandemic and some 6 months before. And so what happened was that when the pandemic started, we had the opportunity to track changes in behaviors over time. And one of the things that was really starkly obvious to us was that physical activity dropped off a cliff. And so this graph shows pretty clearly that our cohort that we started following earlier maintained their high level of physical activity at follow-up, but then once the pandemic rolled around, dropped off. Our cohort that we picked up a little bit later also had that high level of physical activity that in their first follow-up, which was during the early months of the pandemic, dropped off as well and really didn't recover, at least within that first year. Substance use, though, stayed pretty flat. A little bit of wavering here, maybe dropping from 20 to 15%, but if you sort of look at this holistically, that's pretty even across the boards. And no statistically significant difference in a difference analysis suggesting there was a signal that we could tease out here. And while I don't have it here on the slides, we spent a lot of qualitative work doing Kristen Hoff led some interviews with our youth in this cohort about their substance use and how they could still access products even during stay-at-home orders and school closures, basically saying, if I go on my social media app and have a shout out from a friend or an acquaintance, I can get the stuff delivered, over the fence in the backyard of my house if I leave a little bit of money under the doormat. Or even in some cases, notably, young people saying that my parents would give me cannabis products to help me with anxiety during the pandemic. And so there's a lot of access channels whereby our young people were using these products and getting these products, even though they didn't have some of the same informal sources that they would have through in-person education and contacts in schools. So a few last thoughts here before we go. One, in your practice, your patients are using cannabis. Most of them aren't, but probably 1 out of 5, 1 out of 4 of your high school age patients have used cannabis in the past 30 days. And they're using it in a variety of different ways, whether they're smoking it, vaping, eating, drinking, dabbing. They're getting it, and they're probably using it more than one way. And for these newer or growing in popularity ways of consuming, there's a lot we don't understand about the health effects. But for all of them, if they're consuming THC, there's a real risk of cognitive impairment. But at the same token, these adolescents don't view this as a dangerous behavior, and in many cases contrast in their minds with cigarette smoking, which is they view as a completely different entity to, say, smoking marijuana. And now I mentioned it one more time, I don't mean to repeat myself, but yes, legalization not only has been the will of the voters, but has some meaningful benefits potentially, but billboards like this that have been showing up around California, including here in San Francisco, certainly have downsides in my view for youth. You cannot put a billboard like this for a tobacco product, but we seem willing to accept this for a cannabis product. And so, again, I'm not in the position to be making recommendations for pediatric practice, but a few things that I would consider or come to mind as areas to explore is how to have a conversation about marijuana product with kids and their parents who are very likely uncertain about all the different ramifications and implications and risks and even benefits of cannabis use. And young people, they don't want finger wagging. They don't want to be told it's dangerous. They want to hear the truth and all its complexities and nuances. And so figuring out ways to communicate that to young patients is going to be very valuable and appreciated by those young people. And I would say overall, from any health organization, we should be backing policies that protect kids. So strengthening clean air laws, whether it's indoors and outdoor spaces, the same way we think about tobacco smoke and secondhand exposure, we should be thinking about secondhand exposure to cannabis smoke. I believe we need stronger limits on commercial advertising. I don't think those billboards are appropriate in areas where kids are going to school and playing. And putting more limits on products that appeal to kids. So particularly flavored products and candy-like cannabis formulations. And then we need a lot of research. There are things that we really honestly do not know. And we need that research so we can put appropriate standards and restrictions on new products where right now there's a lot of things out there in the Wild West. And so with that, thank you so much for the opportunity to present today. It was really a privilege and an honor, and I appreciate it. Thank you for your time. And I think we've got some time left and maybe a couple of questions in the Q&A.
Thank you so much, Dr. Chaffee, for that informative and fascinating talk. Please, anybody who has any questions, go ahead and type them into the Q&A section, and I'll read off the question, and then Dr. Chaffee will respond with an answer. So we have a question here. For the study examining hypothetic use and teens' opinions about risks and benefits of cannabis, what frequency of use was proposed for them to base their judgment on?
Yeah, so in those measures, we said, imagine that you use the product. The exact wording there was, we said, imagine you use it, I think we said once or twice per day. Sometimes you use alone, sometimes you use with friends. So it's daily use. And that idea of using alone tends to resonate with younger people, that we're really talking about a heavier level of use than this just once in a while periodic use. It's an interesting question. Perhaps in one of our future studies, we could change that wording to more of an infrequent use scenario and see how opinions change. But that's the way the questions were originally worded, based on instruments developed in the early 2000s for cigarette smoking.
Thank you. We have another one here. As a pediatric palliative care provider, this person finds cannabis to be exceedingly beneficial for symptom management for their patients with chronic illness at the end of life, especially compared to opioids and benzodiazepines. Can you speak a little bit towards the differentiation between this appropriate use of cannabis and its recreational use?
Yeah, thank you for making that comment. Really important to differentiate between the two. Throughout this talk, when I was talking about health risks for adolescents and my concerns, really focusing on a commercial cannabis marketplace where recreational products are widely available to kids and they're using it to get high. In a supervised medical setting, very different situation. I think we're talking about a much more narrow use and under very narrowly defined conditions where that's appropriate. But yeah, I don't want to speak exclusively that this is only a harmful product, but that certainly we've talked about FDA-approved medications derived from cannabinoids that have been shown safe and effective. So yeah, it's a complicated question, both chemically, medicinally, and socially. My perspective as an epidemiologist looking across the population, my biggest concerns are for the vast majority of young cannabis users who are using it recreationally.
Thank you. And we have another question. We are all seeing many adolescents with daily heavy cannabis use, which is worrisome given the long-term outcomes that you talked about earlier. Can you comment on mental health impacts, especially related to any potential increase for schizophrenia or other psychoses?
Yeah, great comment. I don't have specific research on the top of my head that I can turn to give you a numeric estimate or a specific study on the risk of some of those serious mental health illness outcomes among cannabis users. But I do notice that in the comment, there's a real irony there that many young people and older people are turning to cannabis as a way to manage anxiety or depression or stress. And we do need to make sure that they're not inadvertently putting themselves at higher risk of some of those same outcomes they're trying to avoid.
Mm-hmm. Thank you. And also, is there any way for a cannabis user to tell us whether they are impaired to drive? How can users tell whether the effects on themselves or their other possible drivers have sufficiently worn off to make driving safe? I'm not sure how also it's monitored legally, similar to like the breath test for alcohol consumption.
Yeah, so, great questions. There's not a standard that I could point to or even a heuristic in terms of assessment. I mean, I think about those commercials, public service announcements on television saying even buzz driving is drunk driving when it comes to alcohol use. It's one of the challenges with cannabis too is depending on how you've consumed it. If you've consumed it as an edible, the onset and duration of action may be much longer than if you had smoked it. So that's another consideration when trying to say, are you now no longer impaired and can go and engage in regular activities? So I don't have a great answer to that other than the safest choice is always to be completely substance-free before you walk into a motor vehicle.
Thank you. I'd like to thank you again, Dr. Chaffee, for coming today to talk about cannabis use in kids in California. This was incredibly informative and fascinating talk. It will be also posted online if anyone wants to check it out there. Thank you for taking the time to speak with us today.
Thank you so much.
I'd like to add my thanks, Dr. Chaffee. That was a very informative and relevant presentation. Really appreciate you spending your time with us, and thanks to everybody for participating. We'll see you all at the next Grand Rounds.